Hello, everyone, and welcome to today's MenMD The Focus webinar, BPH Online Clinic. My name is Ashton, and I'll be your moderator for this event. I work on the marketing team here at MenMD, and I'm excited to be hosting this session today. Before we get started, we have a short disclaimer that we need to review.
The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
Alrighty, with that being noted, I'm pleased to introduce today's presenter, Dr. Francisco Gelpi. Dr. Gelpi is a board-certified urologist who specializes in urologic oncology, urology, robotic surgery, and clinical research outcomes, and is located in Memorial City, Houston, Texas. Today, he's going to discuss what the prostate is, the symptoms of BPH and how it impacts a man's life, the treatment options for BPH, and then hold a live Q&A to close out the webinar.
Good evening, everyone. It's always a pleasure to have the opportunity to educate people on what I think is a very important topic, particularly when it comes to men's health. So we'll talk a little about what's the prostate, where it's localized, what's its role, what's BPH, and then what sort of options we have nowadays, which they keep growing and growing. The list keeps getting larger and larger, which is a good thing. Sometimes it just makes the discussion a little more cumbersome, but that's what we're here for, to try and educate and guide patients through the whole process. So let's talk a little bit about the prostate. The way I like to explain this to my patients is this is an organ that's localized right outside of the bladder. So the way I want you to think about it is you have the bladder on top, which is a reservoir, and then you have the prostate, which will regulate how much amount of urine can flow through it. So when we're young, this is actually a small organ, but as we start getting older or more mature, the inner part of this structure starts getting narrower, and this is what starts compromising the function of the bladder. Throughout the webinar, I'm going to be using a number of words that I know that can be a little confusing, but one of the most critical things that I like patients to, right from the get-go, start thinking about is, even though we're going to keep mentioning the word prostate, really what I worry about the most is the bladder, because the problem is, as this prostate is starting to make it harder for the bladder to empty, we run into the potential to start compromising the function of the bladder. And the bladder should last you until we die. So technically, it is an organ that we need to protect, and unfortunately, it can start suffering silently for a number of years. We'll get into that in a minute. But again, it's super important to start thinking also about not only BPH being a prostate issue, but also a bladder health issue. So there's a number of conditions that we're going to see associated with the prostate. They're all different. People usually worry when they have some sort of urinary symptoms about the possibility of this being associated with the prostate cancer. Fortunately, this is a very uncommon situation, as most of the patients that have prostate cancer, they will not show up with urinary symptoms, but rather we will identify them when we are screening them with, say, a red cell examination or a prostate-specific antigen, which is a blood test that every man in the ages between 50 and 70 should be doing at least on an annual basis. But you're also going to hear about conditions as prostatitis. You're going to hear about, again, this fascinating term of BPH, which stands for benign prostatic hyperplasia. So let's get into it a little bit. The way I want you to think or picture the prostate is we're dealing with an entity that has three words: benign, because it's non-cancerous, therefore it's not related to cancer. Hyperplasia means that there are more cells than we expect them to be. Basically, there is an enlargement. And then obviously prostatic, relating to the prostate gland. So this is a very common condition that men start suffering typically after the age of 40 or 50. What typically happens is that for the first number of years, your bladder actually is compensating for that extra work that it has to put in order to facilitate the emptying of the bladder. And that's why I'm going to keep going back to the importance of bladder preservation and bladder health. So super important. Again, some of these things are going to sound repetitive, but I just want to make sure that patients don't get confused or worried about. But BPH is not prostate cancer. It will not lead to prostate cancer. It can exist or coexist with prostate cancer. And as I mentioned just a couple of minutes before, the reality is most of the prostate cancer patients that we identify today, they will not really be secondary to the patients presenting with any urinary symptoms because of the cancer. As I also mentioned, there's a very important screening test that we can utilize, which is called a PSA. Every gentleman between the age of 50 or 70 should be doing this on an annual basis. And very important, this is not something that would give us an idea about the intensity of the urinary symptoms or can distinguish from prostate cancer and BPH. Interestingly though, the more volume of tissue that a patient has, the higher we expect that PSA number to be, because it's a number that is very dependent on the amount of volume of tissue that we are dealing with. So the mental picture that I want you to think of is the prostate is a donut or it's a fruit. And basically what happens is the pulp of that fruit will get more voluminous. So as this is happening, you're going to see that the urethra is supposed to be going right through the middle of that donut hole. But there is an element of that growth that happens to the inner portion of the prostate as opposed to the outside. The reason for that happening is that the prostate has a capsule or a pseudocapsule that will actually minimize how much it can grow outwards. So little by little, it starts growing inwards. That impingement or narrowing of the urethra is really what then leads to this very common battery of symptoms that include a slower stream, drilling of urination, harder to get things going. And then it's really the change that the bladder has to suffer, the one that leads to what we call the irritative symptoms, or the urgency, the frequency, and the sense of incomplete emptying. The reality is most patients will present with one or multiple of those symptoms, but not everyone is going to experience this exactly the same way. That's one of the reasons why sometimes it's very important to ask patients the right questions. And we'll go through that in a minute about the standardized questionnaires that we have available in order to try and make a diagnosis. So the typical symptoms, I divide them in two categories: obstructive or irritative. The obstructive symptoms are the ones that will restrict the flow. And as I mentioned just a while ago, that will be that slower stream. That will be making it harder to get things going. That would be that post-void dribbling that typically drives patients crazy. And then we have the irritative symptoms that are more along the lines of the burning, the stinging, the waking up at nighttime, that sense that you have not emptied completely. If these symptoms go unattended, the reality is a lot of them can lead to recurrent urinary tract infections, which is actually a very common presentation that we see in our patients, as well as developing not necessarily kidney stones, but rather bladder stones. And again, as I'm going to keep honing on and mentioning multiple times, it can actually lead to bladder deterioration. The reason for this is your bladder is actually trying to compensate. And since we have to urinate every day multiple times, we get very used to whatever is our personal experience when we urinate. So I always throw the same question at patients. If I wanted them to compare the urinary stream to when they were 15, 100% of those patients are going to tell me that things are slower now than they were before. But when I ask them, okay, let me challenge you, when did things actually change? Can you give me a date? There's no way you can do that, because we actually acclimate and get used to things starting to slow down. And at some points, the balance then tilts the other way. That's the time when we actually come into play. So this is a very, very prevalent condition. Again, starts after the age of 40 or 50. That does not mean that every gentleman will experience bothersome symptoms at that time. But the reality is it's a condition that ultimately would have a huge impact, not only on men, but also on their partners and the people that are around them. In addition, it could lead also to problems particular with their sexual quality of life. Oftentimes this is because of the medications that some patients have to go on. Oftentimes it's because patients struggle with getting or resting at nighttime. Again, it's a very prevalent condition that has an impact in multiple arenas of our life and those of our loved ones. So yeah, this is, again, exactly very, very common up to the age of 40 or 50. I actually start screening for men, asking them the questions a little before the age of 50, but that typically, uniformly, it's the age where we start seeing that it starts having more of a profound impact. What sort of risk factors or things we have associated with it? The reality is there's a number of theories, but we really don't have a clear explanation. It's almost like our genetic material. It's intended to tell the prostate to start growing in that age. We can see that there's a connection between patients that tend to be more on the obesity end of the spectrum metabolic syndrome, lack of exercise, and so forth. There is a familial predisposition, but the reality is we still cannot 100% predict who will develop the symptoms or not. So very, very important. We have a number of standardized questionnaires that we can utilize in order to gauge the intensity of the symptoms. We typically will offer these to any patient over the age of 40 or so that shows up to our clinic, but that doesn't mean that a patient has to wait until they come into the doctor to start trying to gauge if they have any of these issues or not. The most typical questionnaires that we utilize are the AUA symptom score or the IPSS score. These are things that we can easily look for online. But the reality is, any patient whose urinary symptoms are starting to affect their quality of life, it's someone that should come in, get screened, and have a conversation with their doctor. So how do we diagnose this? The reality is the rectal examination, we are fans of it because it helps us screen for prostate cancer, but there's no way that we can honestly gauge the size of a prostate by doing a rectal examination. We can have an estimate, but there are multiple studies that say that these things can actually be a little not as straightforward as we thought. We can also measure a number of things. Typically, I will have my patients urinate, and then I will measure their residuals of urination. Some of us will also incorporate some flow testing, and this is just to try and compare the patient against what we call normal levels. But again, I think that this is a very, very subjective condition, and as such, the moment it starts affecting a patient's overall quality of life, I think that's the moment that we need to start seeking help. So let's get into the meat of it, which is basically how do we treat this? The reality is we have a plethora of treatment options that can range from very conservative tools to more aggressive or invasive. We'll walk through most of them, but let me just be very, very clear right from the get-go. There's multiple ways to skin that cat. The reality is a lot of these treatment options, you need to have a conversation with the doctor, get a sense for what resonates the best with you or your family members. And again, it's not a cookie cutter approach. Everyone's anatomy is different. Everyone's symptoms can be a little different, and there's particularities about every individual that need to be individualized when we are offering treatment options. So when we refer to watchful waiting, this is basically a way of saying, hey, let's not intervene. Let's just pay attention to what we are doing, in particular, paying attention to what we're eating and drinking, and see if we can identify things that will worsen that patient's ability to urinate. I'm a huge fan of always asking my patients a little about their diet, things as coffee, caffeinated products, spicy stuff, alcohol, smoking, chocolates, tomato intake, just to name a few. These are things that we know that are related to irritating the bladder and hence causing an increase in the irritative symptoms. Oftentimes I have patients who suffer from constipation, and then this can actually irritate the bladder as well. So it's very important to also discard or exclude the things that we can control without a medication or intervention. Now, more and more, the first line of defense for most of my colleagues would be to then incorporate some kind of medication. And we basically have two categories of drugs that we're going to talk about. The first one is what we call alpha blockers. These are medications that are designed to relax the prostatic urethra. The idea behind them is they will then make the stream flow a little easier, but they're not perfect. Oftentimes, depending on the patient's anatomy, they will not be as effective. They can also have an impact in the patient's ability to ejaculate, a very common side effect, which is called retrograde ejaculation. It's actually the number one reason why my patients would like to stop the medication. Oftentimes, it can affect the quality of the erections. And then very seldomly, we will see patients complaining of dizziness or having fainting episodes where they get what's called orthostatic hypotension. This used to happen with the older generation of these drugs. But again, as I tell everyone, medications are not innocuous. They will always have some sort of side effect. And even though this is a very time-tested and very well-tolerated medication, in some patients, it will lead to some of these side effects. The other kind of medication that we have are what we call 5-alpha reductase inhibitors. The intention is for them to shrink the prostate. I'm not a huge fan of them. I use them every now and then, but I don't like them that much for the simple reason that they can have an impact on the patient's sex drive. They can have an impact on the way that their PSAs or prostate-specific antigen is interpreted. And if you have someone that's versed in doing that, then no issue. But unfortunately, when these are given by, say, primary care physicians or people that are not paying a close attention to your PSA, they can actually lead to patients being identified with prostate cancers in more aggressive stages of the condition. The other downside of the medication is that it takes a while to start working. So typically, as opposed to the alpha blockers, which would start working in hours or days, 5-alpha reductase inhibitors are going to take in the order of weeks and very likely months in order to become noticeable. And then, interestingly, we have started incorporating a lot of the medications that we typically use for erectile dysfunction. These are called phosphodiesterase inhibitors. The most notorious one being tadalafil or Cialis. And what happened was when these first studies were done, researchers started noticing that patients started to urinate better when they took them. So they don't help everyone, but there's a good chunk of patients that actually noticed quite a drastic improvement. So in those where you see that benefit, you can actually have the dual benefit of not only improving their erections, but also their ability to urinate. And then let's start talking about some of the more novel or newer therapies that we have. Resume or water vapor surgery is one of the newest kits in the block. It's one of the most helpful things that I have in my armamentarium. The reason being, it's a very simple procedure to do. It's an office-based procedure where you don't need general anesthesia. The way this works is we're going to inject vapor into the pulp of the prostate, and that vapor will lead to some tissue damage by increasing the temperature of that tissue. Ultimately, what will happen is your body will absorb that tissue, hence creating a cavity or a space. So what I like the most about it, or the way I like to explain it to my patients, is I'm trying to deflate their prostates. It's a great tool because I can utilize this for a number of different anatomic configurations. And we also have the ability of incorporating into patients that have very significantly large prostates. So it's a great tool for that guy who in particular wants to preserve their ability to ejaculate, because we will be respecting their bladder neck. And hence it's become one of the most common alternatives that we typically offer our patients. Can we get the next slide so we can watch our video?
Resume water vapor therapy is a non-surgical treatment for BPH. Resume uses the natural energy found in steam to shrink the prostate. In just seconds, this precise technology destroys enlarged prostate tissue while minimizing any effect on surrounding tissue. Resume is a potential alternative to drug therapy, permanent implants, and surgery. It preserves sexual and urinary functions, and it's clinically proven to safely and effectively reduce BPH symptoms. Potential side effects include painful urination, blood in the urine or semen, pelvic pain, and urinary frequency, retention, or urgency. The procedure is performed right in your doctor's office or outpatient center. You do not need general anesthesia for the procedure, and Resume therapy lets you quickly return to normal activities. Talk to your doctor about Resume if you're no longer comfortable with your BPH symptoms. Drug therapy isn't working for you. The side effects from drugs are impacting your quality of life, or you don't want to have surgery or get an implant.
The other thing that I would like to add there is in patients who undergo Resume, and let's just say for whatever reason the procedure did not work for them, or their prostate continues growing and they need something else, it will not preclude us from then doing a different procedure. Typically, this procedure will last in the order of, or at least the data that we have would say that it will last at least about 10 years. My suspicion is that it actually lasts longer than that, but we don't have long-term follow-up data to go past that, just because it hasn't been around that long. But more and more we are incorporating into our arsenal. Patients actually are very happy when they get it done because of the simplicity. Most of my patients, I treat them with nitrous oxide, And then I also perform a prostatic block when I'm doing the intervention. So it's very simple for them to drive in and out. They don't need to have someone coming in to pick them up or whatnot. So a great alternative, again, for the right patient who's got an anatomy that is ideal for it and whose prostate typically measures, I would say, in the order of less than 90 grams or so. No general anesthesia, as I mentioned, no permanent implants, and the retreatment rates that we are dealing with are actually fairly low compared to other modalities. So the prostatic urethral lift or UroLift, it's another one of those newest kids in the block. It also has the availability of being done in the office setting where we don't need general anesthesia. Same story as far as the position, the setup, very similar to when we would perform a resume. The only particular thing about it is that we need to utilize an implant. The way that I like to explain it is this implant, it's sort of like an anchor that will mechanically unobstruct the prostate. And the idea is this is permanent, so it stays with you. Your body will just create a coating around it. In the properly selected patient, it is a great tool, but it's very important that we go through the motions of doing the proper workup in this patient because we need to have a particular kind of anatomy that's more suited for it. As far as the large glands, we actually can treat fairly large prostates up to 120 grams. But again, these needs to be prostates that have a very particular anatomy so that we can have a long-term effect. The retreatment rate's a little larger or a little higher, but on the flip side, it's the only thing that we can do where a patient will go home without a catheter. And for a number of patients, that's a very important thing to consider. So as I mentioned a couple minutes before, as we keep walking through these options, very important that you kind of get a sense for what resonates the best with you, what makes the most sense, and which sort of things are more critical in your decision making. Then this is what I would call a next level intervention. Why is that? Because the green light or basically laser photovaporization is a procedure where we require general anesthesia. It's one of my favorite procedures. I call it my Swiss Army knife. I basically can treat any prostate with this procedure, but it needs to be done in the operating room setting. For some patients, particularly when they have other medical comorbidities and they are not candidates to undergo anesthesia, that might be a limiting factor. We typically utilize this for patients who have larger prostates and who are not as worried about their sexual function afterwards, not because it will affect their ability to be intimate or the quality of their erections, but because very likely it will compromise their ability to ejaculate in an antegrade or forward fashion. The reason for that is when we do this procedure, we have to remove an area of the connection between the bladder and the prostate that it's important when we're trying to ejaculate. So this is one of the reasons why UroLift and Resume have become such important options, because as we've been asking patients what are the critical things that they want to accomplish when they get their prostate procedures done, the ability to ejaculate was actually higher on the list than we ever thought. But for men who are not really worried about that, this is an amazing tool and one where you can actually see a drastic improvement in the quality of that urinary flow almost immediately. Retreatment rates are actually fairly low. I think that number might actually look a little higher than Resume for the simple reason that this is reserved for prostates that tend to be larger in size. And again, there's no involvement of any permanent implants when we do that. And then the transurethral resection of the prostate, this is basically the gold standard when it comes to surgical procedures for the prostate. This is what we basically compare everything to, for the simple reason that this is what's been around for the longest. Interestingly, this is a procedure that I've not had to perform for probably the last 8 years or so, not because I don't think that it's a helpful procedure, but rather because I think that we have newer technology that can give us very similar results in a way simpler fashion. The number one downside that I would say for TURPs is that these need to be done in an inpatient setting. So these patients need to stay admitted at least overnight, oftentimes an extra night. And that's because the way we perform this is we're going to use a loop that will cauterize and cut into the tissue. and that can increase the potential for the patient to bleed afterwards. So these patients need to be irrigated overnight, as the ability for them to clot or make sure that that bleeding stops is something that we're sorting up before we can send them home. Again, it's a standard of care. In some instances, you might actually go and meet with the doctor that this is the only thing that they perform. And the reality is, if you like your doctor and you are happy with him or her, I don't want to mention that this is not a proper option, because the reality is there are a number of urologists that perform amazing TURPs. I have just found that in my book, it's not something that I need to heavily rely on. And then this will be probably at the other end of the spectrum, which would be a prostatectomy, which, if we want to be very proper, it will not be a radical prostatectomy, which is what we typically do for cancers, but rather a simple prostatectomy, where we will be removing that inner portion of that pulp of that prostate. This is actually a way more aggressive procedure. Typically, I do them in a robotic fashion. In order for me to do this, I need to make an incision at the level of the bladder, and then remove that inner portion of the prostate. We typically reserve this for way larger prostates, but the ability for us to remove tissue, it's so substantial that once these patients are taken care of, they really don't need anything down the road. But again, the recovery, it's a little more cumbersome. This needs to be done in the inpatient setting. Typically, patients will stay admitted for at least one night. They will go home with a catheter for at the very least 5 to 7 days. So it's actually way more rocky recovery as compared to some of the less aggressive or invasive options that we have. But again, in the right candidate, it's a great tool. That's why it's so important to go through the proper workup in order to identify which tool is the most appropriate for that patient. And then just for peace of mind, most of these things, they tend to be covered by most of the traditional or conventional insurance carriers that people typically come with. But granted, it's important to make sure that we reach out and make sure that whatever alternative we have decided on, that this is something that is covered by your insurance. This is typically some of the legwork that my staff will handle, as I'm sure that most of the other physicians that you go to will also have the staff who are well trained and well versed in how to handle. So again, just to briefly summarize, BPH, or benign prostatic hyperplasia, is basically that enlargement which ultimately would lead to obstruction of your urinary flow, secondary by a prostate that is growing, particularly in the middle portion of it. It's not associated to cancer, and it's a condition that is exceedingly prevalent, typically up to the age of 40 or 50. We do have a number of options in how to tackle this. This will ultimately depend on the intensity of the symptoms and the impact that it's having on a patient's quality of life. And these alternatives can range for very conservative maneuvers, as keeping an eye on your diet, minimizing the amount of fluid intakes or certain fluids at certain times, all the way to very aggressive measures where we can actually remove a substantial amount of the tissue that is in that inner portion of the prostate. So super important that when you have this conversation with your physician, you make sure that things make sense to you, that you go through the proper workup or evaluation to identify which particular things about your anatomy or your case need to be considered when making that decision. And ultimately, as I mentioned right at the beginning, super important that the reason we do most of these things is because we ultimately want to preserve the health of the patient's bladder. So with that being said, I'm going to send it back to Ashton, and I'm guessing we are going to open it to some questions.
Yeah, we are going to open it to some questions. I have just a couple more slides here to show our attendees real quick. So if you're interested in contacting your doctor about Resume, or contacting Resume rather, to figure out how you can be covered with your insurance, there's some phone numbers there and operating hours. This will also be available in the recorded version as well, so no need to worry if you miss it now. Yeah, as far as the next steps, definitely want to consult with your urologist to determine which of the mentioned therapies will be best for you. And I'd like to thank our sponsor, Boston Scientific, for helping us put this together before we hop into our Q&A. Here we go. So to start off, we got some general BPH and prostate questions. First question, does BPH cause pelvic floor pain?
It can. I actually have a number of patients who suffer from an entity that we call chronic pelvic pain syndrome. The way I like to explain this is almost like patients are having spasms of their pelvic floor structures, prostate being one of these. And oftentimes a combination of stress, anxiety, dietary issues, and then this lingering phenomenon of prostatic obstruction can lead to a certain degree of pelvic pain or discomfort. If that is something that a patient is experiencing, the more recent he needs to then have an evaluation, ideally by a urologist.
Alrighty. The next question here is related to prostate cancer. This person wants to know, what are the first signs and symptoms of prostate cancer?
So the thing about prostate cancer is that typically it's a very silent condition until very late stages of it. That's why, when we were talking at the beginning of the presentation about, symptoms and things that you expect to see with prostate cancer, the reality is nowadays with the advent of earlier screening, we really don't see patients coming in with these sort of symptoms. And I know that oftentimes patients will get anxious if they have any of these symptoms because they think, well, this might be that I have prostate cancer. So typically in those patients who have advanced prostate cancer, what you would expect to see are, you can see blood in the urine, you can see a difficulty with urination, pains, but substantial amount of pain in their pelvis. Again, these are not the typical things that we see nowadays, but if a patient has any degree of concern or anxiety, I think that at the very least they should have a conversation with their doctor and then incorporate some of these questionnaires that we talk about and see if they actually meet criteria to start having a more, let's just say, dedicated conversations with regards to if they need to be screened further or not.
Alrighty, and a follow-up for that, I know you just mentioned there's early screening to be done. Typically, how far out would that be done, or what would trigger someone to go in for the screening?
So screening uniformly should be performed in men between the ages of 50 and 70. The reality is it's not a cookie cutter approach. When I have patients who have a strong family history of prostate cancer, I actually start the screening earlier. There are certain ethnicities that we screen earlier as well. So for starters, I'm Puerto Rican, so Hispanics as well as African Americans, we have a higher predisposition to harbor prostate cancer. So I typically would recommend starting that at age 45 or so. On the upper end, we normally recommend for patients up to 70 years old. But the reality is if the patient has a life expectancy of at least more than 10 years, you can continue screening way past that 70-year-old. So there's really not a clear cut, hey, this guy from this on till this age. But as a general rule of thumb, at the very least between ages 50 and 70, that should be carried out on an annual basis. And unfortunately, that also includes the rectal examination, which I know that a lot of men want to avoid. But the reality is that there's still a significant number of men. In my practice, it's in the order of, I want to say 10 to 15% of men are diagnosed with prostate cancer, not because of their PSA, but rather because of their rectal examination. I feel something that I don't like how it feels. We do a biopsy, and that's how we pick it up. So very important to make sure that you check that box at least once a year and get both done.
Righty. Couple of lifestyle / natural treatment questions here. I saw this one a handful of times. A lot of people wondering what the optimum diet or food choice would be for minimizing prostate issues.
So I get asked every single day of my life that same question. It's sort of a challenging question because we have tried and identified what sort of supplements, what sort of particular elements of our diet, what sort of lifestyle issues will lead to a life that will prevent prostatic issues, either from urinary symptoms standpoint or from a prostate cancer standpoint. And the reality is we have not been able to identify that magical solution. What I tell patients is heart healthy lifestyles are typically prostate healthy lifestyles. And why do I say that? Heart healthy lifestyles are typically what when we want patients to, keep an eye on their diet, keep an eye on physical activity, minimizing stress, trying to sleep right. All these things ultimately tend to reduce inflammation in your body, which we have seen that it's typically associated with the risk to have either prostate cancers or a growth of that prostatic tissue. Diet in particular, I think it's a very critical one when we're dealing with patients who are obese or patients who are diabetic. These are all things that feed into what we call the metabolic syndrome. And again, if you are a little more active, if you keep a closer eye on what you're eating and drinking, you actually reduce the probability of having any of the above. So I'm not saying that there is a particular suggestion. I am not a dietitian or a nutritionist, but I typically tell my patients that the key is just moderation, finding everything in balance.
Certainly. Alrighty, moving right along, a couple of BPH questions. This person wants to know, or they said that they are suffering from erectile dysfunction and they're wondering if their enlarged prostate may be causing this. And if not, where else should they look?
Okay, so I get this one asked a lot. I think a lot of it is because the 2 a.m. infomercials make it sound like your prostate, it's the explanation for your ED, for your sex drive issues, for your urinary issues, and everything that's bad with you. And the reality is that no, it's not the prostate, but oftentimes the effects of prostatic issues or the medications or the treatments that patients are incorporating in order to address those can ultimately affect the quality of their erections. So for starters, as I mentioned at one point, one of the most typical things that men would be on would be alpha blockers. We know that there's a decent number of those patients that, because of the medication, will have an element of erectile dysfunction. In addition to that, I know that it sounds simple, but you're going to see a number of patients that because of their BPH, they're going to be waking up multiple times a night. Well, that translates to this patient not resting as much as they should. We already know that men that don't have restful sleep, they ultimately can have lower testosterone levels than an average gentleman. So again, these things can work in sort of like a multifactorial fashion. So even though the prostate directly will not lead to these issues, it can definitely play a role in leading to it. But I'm sorry, but the most common reason for erectile dysfunction will ultimately it will be associated to either a vascular or neural issue. The vascular component oftentimes has to do with atherosclerosis, which we routinely associate that with heart issues, but it can start at the level of the penis or the vessels that go to the penis. And the other very, very common reason that we see a lot of it has to do with diabetes, which ultimately affects the quality of the nerve go to the prostate. To the penis.
Alrighty, thank you very much. Next question here. Could my ejaculation be restored to normal levels after taking tamsulosin for some time?
Yes, it's actually it's a side effect of the medication. And once a patient stops the medication, typically in the order of 5 to 7 days, once it's completely washed out of the patient, the ability to see that ejaculate. And let me be clear about something. It's not that the patients cannot ejaculate. It's just that they will not see the white substance that we typically see associated with it. And that's because the bladder neck is relaxed. So once they stop the medication, they should go back to ejaculating the way that they were used to prior to taking the drug. Excuse me.
Alrighty. Next question is kind of similar, but a little more broadly aimed towards BPH treatments as a whole. They're just asking how they can get their sexual activity back after following a BPH treatment, not citing any particular one.
Yeah. So I guess that will depend on what alternative or treatment option they go with. Broadly speaking, if we are incorporating medications, as I mentioned earlier, the medications typically are not innocuous. Alpha blockers can have an impact on their ability to ejaculate, so stopping the medication can actually improve that. In men who are taking the 5-alpha reductase inhibitors, typically stopping the medication can restore their sex drive, but that can take weeks or months to happen. In those men that are taking the PDE5 inhibitors like Cialis, Viagra, Levitra, these medications actually are the only ones that I'd say will improve the quality of their erections. So there really is nothing to worry much about there. And as far as the surgical options that we describe, other than telling patients to take it easy for a week or so after the intervention, they can go back to their normal sexual practice afterwards. So there really should not be any major impact moving forward as far as going back to being intimate.
Alrighty. Next question here. Any feedback or advice on how I can get over increased heart rate when prescribed tadalafil for BPH?
Impact on what? I'm sorry?
Increased heart rate when taking tadalafil for BPH. They want to know how they can possibly address this.
It's not typically something that I see. If anything, these are drugs that in some patients can lower their blood pressure a little bit. And maybe the reason the patient is having an elevated heart rate is because their blood pressure is going down. So that is actually a mechanism of compensation in their body. So that is someone that if they are experiencing that side effect, I will definitely caution them about not to keep taking the drug, and then definitely have a conversation with their doctor.
Alrighty, this one is somewhat similar. Person says that they're on a low dose of sildenafil that relieves all of their BPH symptoms. However, it destroys his lower back. Is there any way to counteract this?
Yeah, it's a very common side effect, particularly with sildenafil. It also tends to give a lot of headaches, reason for which I prefer tadalafil or Cialis. So oftentimes what I do tell patients is, if one of the drugs it's causing these symptoms, and sometimes switching to a different one can be a way to start, or reducing those, or changing a bit the schedule that they take it. But I would definitely start with asking, that patient, I would have him reach to his or her doctor and see if there's a way that we can look for an alternative and start there.
Alrighty. This one's a little off topic as far as the last three went, but this person wants to know if the resume treatment can be repeated. I know you said there's typically last about 10 years, but.
So yeah, I've seen individuals where probably the first time the procedure was not, let's just say it wasn't performed to the standards that we should have. No, I'm just kidding. The reality is oftentimes when you perform it, you can have tissue that gets unmasked when you do it. And in the last 5 years or so, I've actually had 2 patients where I've repeated it, and they've done stellar afterwards. So one of the good things about the resume is that it really has no impact on precluding you from doing any of the alternatives that we have to treat the prostate, including repeating a resume.
Alrighty. Okay, one question here. This one is about the transurethral resection of the prostate. They want to know about effects on ED. I don't believe that that was listed in the bottom there of the slide.
Yeah, but I mean, as a rule of thumb, none of the interventions or surgical options that we discussed today should negatively affect erectile function. The reason being, and I'm guessing the question comes because oftentimes what people worry about is when they've heard of someone who's had a prostatectomy for prostate cancer, their erectile function goes down. The main difference is that when we do this BPH procedures, we're not having an impact on the quality of the nerves that are responsible for these erections. Put another way, all of these procedures are addressing the problem from the inside out as opposed to from the outside in. When you do a radical prostatectomy, unfortunately, there is a very high probability of injuring these nerves because they are on the outside of the prostate, and you need to dissect them and navigate them in order to completely disconnect the prostate from the bladder. But when you're doing a BPH procedure, you will be treating everything from the inside out. And hence there's that barrier of tissue that will prevent you from affecting them or injuring them. So long-term, none of these procedures should have a negative impact on a patient's ability to have erections, provided that their erections were good to begin with.
Alrighty, that's definitely reassuring. Next topic of questions here is going to be around incontinence and urinary problems. So first question here, this person wants to know, pretty broad stroke, but how can I treat my incontinence?
So that's a very, very complex question for the simple reason that incontinence is not a one kind. There are different kinds of incontinence. So the first thing is that patient then needs to see the doctor so that we can figure out which kind of incontinence he's dealing with. I'm going to oversimplify, but basically, in my mind, I immediately think of three kinds of incontinence. The first one is what you call overflow incontinence. That will be a patient whose prostate is so obstructive that the bladder cannot empty upon giving that direction to go, and it just spills over. Those are the patients that I worry about the most, because that typically tells me that that bladder is really, really suffering and being taken to its limit. That kind of incontinence routinely will need some sort of intervention. The second kind of incontinence is what we call stress incontinence, and that means that the muscles that are responsible for holding the urine are just not working as strong as they should. This is something that we typically see not after any of these procedures, but again, rather after a radical prostatectomy. And the reason for that is because when we disconnect the prostate for cancer purposes, we have to reconnect the urethra to the bladder, and we are fully dependent on a donut-like structure called the urinary sphincter. Well, oftentimes that sphincter can be affected, and its ability to coaptate or hold the urine in place is not as strong or as robust as you expect it to be. If that were the case, first line of defense is normally something as simple as Kegel exercises to try and recruit those muscles to get them stronger. But oftentimes you can end up requiring additional things, coaptate or submucosal injections, artificial urinary sphincters, slings, things of that nature. The third kind of incontinence is what we call urge incontinence, which basically means a bladder that's having involuntary contractions, and those contractions are so substantial that they actually can go past the resistance that the urinary sphincter is exerting, and hence you have the accident. So super critical and important that you figure out which kind of incontinence you're dealing with, because it has huge implications on how you treat it. Hopefully that was not super confusing.
No, that was definitely pretty concise. Thank you for that. Alrighty, next question. How do I fully empty my bladder so I don't wake up every 2 to 3 hours to use the restroom?
The waking up at nighttime conversation, it's actually a trickier one, because there's a number of elements that also play a critical role when we're sleeping. So one of the things that I did not mention at the beginning was one of my first questions that I ask patients is if they have been diagnosed with sleep apnea or if they snore, because we do see a good number of patients who urinary issues at nighttime are magnified by having other conditions, sleep apnea being one of the most common ones. But typically, and just to keep it simple, I actually recommend patients to limit the amount of fluid intake in the hour or 2-3 hours leading to sleep, because again, everything that goes in has to go out. So try and keep the tank a little emptier so that they don't have to empty it as often when they're trying to sleep.
Certainly. Alrighty, next question. What can I take or do to ease leakage and frequent urination?
So first line of defense is always, first line of defense is paying attention to what they're eating and drinking. I do have a number of patients that they do a little bit too much of, say, the coffee or spicy stuff, alcohol, smoking, garlics, onions, peppers. The reality is there might be things that irritate me that don't irritate you. So I always tell patients to do a little bit of detective work and pay close attention to their diet and see if they can identify triggers that lead to this irritative symptoms. Oftentimes there are patients that have what we call overactive bladder, and that's something that is well outside of their control. But you always want to start with, again, the most conservative / simple things before we start moving on to more aggressive ways of managing it. I also am a huge fan of making sure that patients are not dealing with constipation. You'd be surprised at the number of times that this actually worsens the irritative symptoms that they deal with. So again, just starting with very simple, checklist of things that they eat, drink, do, or don't do, and then we go from there.
Alrighty, follow-up for that question is, does Botox treatment help frequent urination?
It does in the patients that have what we call uninhibited contractions, or basically an overactive bladder, a bladder that is acting up beyond our control. So in order for you to decide if a patient will benefit from Botox, you sort of have to do a more elaborate workup, where at the very least you need to take a look inside that bladder, make sure that there's no anatomical explanation for those symptoms. And then typically I would do what's called a urodynamic study, where I'm trying to study the function or the physiology of the bladder. And I have to identify those contractions that are outside of the control of the patient. For those, it's a great tool. But you cannot just say, hey, I have a lot of urgency and frequency, boom, I'm going to get Botox in my bladder. The reason being that Botox, it's not an innocuous intervention. There's about a 10% chance that that patient will go into urinary retention or would have a higher probability of urinary tract infections. But yes, it's a very common tool for patients that have this sort of like more elaborate degree of involuntary bladder contractions.
Alrighty. Next question. I'm 56 and have different urinary flow rates during the day. Is this normal?
I do see that a lot. Oftentimes, the first question that I would ask patients when they tell me that is, tell me a little about your diet. What are you drinking? A lot of coffee, carbonated beverages, that kind of stuff, and ask them about their bowel status. You'd be surprised how much the intermittency or the quality of the symptoms can be affected by dose. Now, the way that I like to explain this to patients is I typically worry when the symptoms are consistent, because if it's an anatomical issue, it will typically not take vacation. So when you see these things being intermittent, almost always there's an element of something that the patient is doing, eating, or drinking.
Alrighty. Next question here is a little more specific. This person says they were told by their doctor they have posterior urethral valves causing a high riding bladder neck. Is this common, and how is it treated?
Exceedingly uncommon. This is typically a pediatric condition. My best guess is that this was a patient that was treated when he was young, and very likely he developed sequela from that. But if the patient has a high bladder neck, there's a number of surgical interventions that you can incorporate. Prostatic, transurethral prostatic incisions, just to name one. This is a patient that definitely needs a proper evaluation with his or her urologist.
Alrighty. I got a question in the chat here. Gonna ask this one. It's related to resume therapy. So this person wants to know what pre-procedures need to be done before considering water vapor therapy.
So typically what I would do is every patient that comes to my clinic with urinary symptoms, we get this questionnaire that I mentioned earlier. And once we confirm that they have this subjective symptomatology, I always like to get at least two things. I typically do a cystoscopy. A cystoscopy is a minimally invasive procedure where we put a camera. It helps me see what their anatomy looks like on the inside. And then I typically do some sort of prostate ultrasound. I normally do them transabdominal, but some people are a little more old school and do them transrectal. As you can imagine, I avoid that last option because they tend to be a little more uncomfortable. I do those because then I can get measurements, and measurements are important because there are certain volumes of tissue that we know will not respond as adequately with resume. Typically, once I have these two things, then that's when I have the conversation with the patient as far as if they are a good candidate or a good fit for it. But the reality is, this is the way I do it. It doesn't mean that every other clinician will do it that way. I also do sort of an indirect test with some patients because what I have seen is a lot of the men that have a pretty good response to, say, tamsulosin or alfuzosin or any of these alpha blockers, indirectly, they also tend to be really good candidates for the procedure. So oftentimes as I'm getting the workup done, I might start them on the medications to see how they respond, not because I'm planning on keeping them long-term, but just to see how they respond. But typically this should not be a pretty long process. I normally, for the men that are very enthusiastic about it and they're very more motivated, once they come in, we should be treating their prostate in the next several weeks. Granted, this depends on your urologist, the relationship you have with him or her, and so forth. But it should be a relatively straightforward process to get going.
Alrighty, we're almost at the end of the event here, but I'm going to ask a couple more questions. So second to last question, my urologist has told me that my prostate is shaped like a flapper on a toilet rather than a walnut. Any issues or reasons to be concerned about this?
Everyone's anatomy is different. We'll sometimes come up with very interesting descriptors. If the patient is having no problems with urination, that's a very unimportant, description. So it all depends on, the symptoms the patient has, if there's any quality of life issues that we're dealing with or not. But otherwise, it's an interesting finding, and that's it.
Alrighty, and the last question for tonight's event. Is there any BPH medication available that does not cause enlarged breasts?
So what this patient is referring to, it's finasteride, which is it's a one drug that can cause gynecomastia or breast discomfort. Yes, so we discussed two other family of drugs, alpha blockers or PDE5 inhibitors. That was one of the reasons I didn't mention it, but that's another one of the reasons why I typically avoid this medication, because I've seen this way more often than I think it's described in the literature, and it sort of scarred me for life. So if this is something that this patient unfortunately is going through, absolutely will discontinue it and then have that conversation with his doctor.
Alrighty, thank you very much. We're going to go ahead and wrap up. If you'd like to learn more about BPH, you have a few options. More resources in the Resource Center on menmd.com. Visit this page to view instructional videos, guides, expert articles, and more. You can also visit menmd.com to compare treatment options. If you'd like to compare any of the treatment options we covered during tonight's event, you can do this by going to menmd.com, navigating to the BPH condition page, scrolling down to the treatment section, and selecting up to 3 BPH treatment options to compare. You can also call MenMD at 857-233-5837 or log in to the password-protected, secure MenMD portal to schedule an appointment with a MenMD personal health assistant. To learn more about the green light laser or Resume treatment options you saw tonight, please visit resume.com.